MC.
Okay.
I was PG and 2-year faculty in Safdarjung.
Okay, so it's been a very long stint, huh? Very nice.
Dear doctors, we'll be going live in 1 minute.
In the masterclass of tibia, we had areas where some people had a little internet problem. So in case that is happening, we can probably close our videos and immediately transfer and come back again.
And no, it is backup is there with them in Omnicoris. Yeah.
Dear doctors, we'll be going live in 30 seconds.
Okay, Pradeep, take over.
Yeah. Thank you.
Doctors, we are live.
Good evening and welcome to the viewers and who are watching us. Today is the Delhi Orthopaedic Association. It's a fracture CME part 2. We are having master class on external fixator, and I'm happy to announce you we have got 5 faculties here, including me and Dr. Manocha, R.K. Manocha. He's a senior orthopedic surgeon in Railway Hospital.
We are live.
With a special interest in trauma and arthroplasty. Good evening. And we have got Sumit Arora. And welcome to the viewers, associate professor, and who are watching us. With today is the Delhi Orthopaedic and Hip Association. A senior doctor from fracture CME Hospital, Dr. We are having master class on external fixators, specialist in trauma and orthopedics. And I'm happy to announce you we have got 5 faculties here, Apollo Hospital, including me, Tandon, and Dr. Manocha, R.K. Manocha. He's a senior orthopedic surgeon in Railway Hospitals. We are live with a special interest in trauma and arthroplasty. Good evening, and we have got Aurora. And welcome to the viewers, associate professor, who are watching us. With today is the Delhi Orthopaedic and Hip Association. It's a doctor fracture CME Hospital. We are having master class on external fixators, specialist in trauma and orthopedics. And I'm happy to announce you we have got 5 faculties here.
Thank you, Dr.
Including me, Tandon,
I'll start
and
screen.
Dr. Manocha, R.K. Manocha. He's a senior orthopedic surgeon in Railway Hospitals. We are live with a special interest in trauma and arthroplasty. Good evening, and we have got
See my screen now.
and welcome to the viewers, associate professor who are watching us. With today is the Delhi Orthopaedic and Hip Association. First speaker
My topic
is Dr. Fracture CME Hospital. We have a master class on external fixators, specialist in trauma and orthopedics. And I'm
biomechanics.
happy to announce you we have got 5 faculties here.
Thank you,
Apollo
Dr.
including me,
Moments.
Tandon,
I'll start
and
screen. When you apply
Dr.
a fixator,
Manocha, trauma and
one
Manocha.
has
He's
to
a
understand that in
senior orthopedic surgeon in Railway Hospitals. We are live with a special interest in trauma and arthroplasty. Good evening, and we have got
see my
Aurora.
screen now.
And welcome to the viewers, associate professor who are watching us. With today is the Delhi Orthopaedic and Hip Association. First speaker is Dr. Fracture CME Hospital. We have a master class on external fixators, specialist in trauma and orthopedics. And I'm
Biomechanics.
happy to announce you we have got 5 faculties here.
Thank you, Dr.
Including me,
Moments.
Tandon,
I'll start
and
when you apply a
Dr. Manocha, trauma and
one
Manocha.
has
He's
to
a
understand that
senior orthopedic surgeon in Railway Hospitals. We are live with a special interest in trauma and arthroplasty. Good evening, and we have got Aurora.
see my screen now.
And welcome to the viewers and the heads of the press who are watching us with Organised or Delhi Joint and Hip Addicts Association. First, after all, CME kind of because we have a master class on external fixation, best is and also we are getting high faculties here. Thank you for having me in attendance. And when you have financial senior officer and we are like special interest in payment and plastic and grinding and we were supervising and also the viewers and the heads of the press who are watching us with Organised or Delhi Joint and Hip Addicts Association. First, after all, CME kind of because we have a master class on external fixation, best is and also we are getting high faculties here. Thank you for having me in attendance. And when you have financial senior officer and we are like special interest in payment and plastic and grinding and we were supervising and also the viewers and the heads of the press who are watching us with Organised or Delhi Joint and Hip Addicts Association. First, after all, CME kind of because we have a master class on external fixation, best is and also we are getting high faculties here. Thank you for having me in attendance. And when you have financial senior officer and we are like special interest in payment and plastic and grinding and we were supervising and also the viewers and the heads of the press who are watching us with Organised or Delhi Joint and Hip Addicts Association. First, after all, CME kind of because we have a master class on external fixation, best is and we are getting high faculties here. Thank you for having me in attendance. And when you have financial senior officer and we are like special interest in payment and plastic and grinding and we were supervising and also the viewers and the heads of the press who are watching us with Organised or Delhi Joint and Hip Addicts Association. First, after all, CME kind of because we have a master class on external fixation, best is and also we are getting high faculties here. Thank you for having me in attendance. And when you have financial senior officer and we are like special interest in payment and plastic.
All of the material, nothing stays in it, all dissolves in 3 to 4 months time. And
we are still using
the most important thing here is
in some places where bilateral is not easy, like in the upper part of the femur. The next evolution is the bilateral one, when we are fixing the bone on either side, medial as well as lateral. The next evolution happened and we got fixation, which is called sectorial. You had a sector of the bone, 360 degree for around the bone is present. Then you fixed from one side, but a sector, that means a 60 or a 90 degree sector. Then came semicircular, which was a 180 degree sector. You were fixing the bone from 180 degrees. At least one pin was passing right across, the other was coming from the other side, and the fixation points were available all through half the circle. And the fourth fixation is a complete circle where you have a fixation all 360 degrees around the bone. Now, all these fixations now tend to get combined also, so which is called a hybrid fixation. Hybrid fixation is the latest thing. Now, multiple things are now available. People would be knowing of OrthoFix, Taylor frame, Ortho-SUV frame. But I have listed the people who have been practicing each of these kind also. The monolateral was Lambert, the bilateral was Chanley's, the sectorial is AOSF, which we'll be discussing today, the semicircular by Volkov, Ognesian, and circular we know very well, Elizabeth. Now, coming to the talk proper. Now, indications of external fixator. We all know open tibial fracture. Dr. Sumit will be talking in detail how do we take care of open tibial fractures by an external fixator. The second common indication is span and scan. When there may not be actual and open wound, but surgery must be delayed for compromised soft tissue envelope. Bone is stabilized without violating compromised soft tissue envelope so that the added insult is minimized. Or span and scan can also be done for a detailed imaging. When you want that imaging to be done in a relatively reduced anatomy and the fracture is complex, and is getting displaced, is comminuted, is getting displaced in all particular direction, so that you cannot understand of it. A CT, if you send, this will be all twisted around. So you apply a spanning fixator and send the patient for scan. That is a very common, very important, what we commonly called as damage control orthopedics. This is done in polytrauma patient who is unfit who has come. There are multiple injuries. There are injuries in the head, abdomen, or chest also. Patient is not good enough for definitive care of orthopedics. So in these cases, you may use the external fixator as a damage control so that the further injuries they do not happen. Infected non-unions, this is particularly useful because in there you will not be able to put an inside the bone. So use that, or a fracture in an osteomyelitic bone. There are two other indications which are described in the book, which is a fixator-assisted ankle arthrodesis and a fixator-assisted high tibial osteotomy. But I have little experiences with these, and they are just for the sake of completion. So we'll now be talking about fixator components and instruments. By common sense, you will need three things. Something to get hold of the bone segment, and for that we use shank screws and stainment pin. Some external support to hold bone segments too. The shanks, pins, and screws, they should go on to some external support. That is what we have in tubular rods. And then the clamps, which join these two together. The joining may be between 1 and 2, or sometimes you may have to join 2 to 2 also. Now, first we will take shank screws and stainment pin. Stainment pin, there are two issues to be sorted out: what diameter, what length. And for shank screws, there are 5 things to be sorted out: diameter, length, tip, thread type, and thread length. There is another kind of stainment pin also, which has a middle threads, as commonly known as Denham pins also. But threads are usually not what characterizes stainment pin. So that's the full range. On the left-hand side, the left is a stainment pin, and all others are different types of shank pins. We'll talk how they are different from each other. So, shank screws and stainment pin. For tibia, the diameter has to be 4.5 or 4 mm. There is another type of shank screws threads, which is called tapered threads. In this, the diameter at the tip is 4 mm and at the base is 5 mm. Material is usually stainless steel. Titanium shank screws and shank stainment pins are available, but we don't have them in India. The drill bit has to be 3.5 mm. The drill bit should be long drill bit. Why it should be so? We will talk later. Now, length. When coming to the length of the stainment pin, you have to understand that the rods cannot be placed too far. So, because they compromise stability, they cannot be too close because they compromise wound and pin site here. So, the stainment pin length should also be chosen with this point in mind. When choosing length, there have to be three important parameters. What is the bone diameter? What is the tissue envelope thickness? And you have to allow for possible tissue swelling also once you have applied it. And then third is a frame skin distance, which I said that if it is too close, it will compromise and the stability. Too close, it will compromise the wound and pin site care. If it is too far, it will compromise stability. However, if you are using it for a short term and then wound care is your primary thing, you should have a space for passing in your closed fist so that you can take care of the wound. And for a long term, closure has to be there because you need stability. Now, tip, thread length, and thread type. We will discuss them all together. The tip is usually the trocar tip, which is a self-tapping tip. You don't need to tap these pins. Then there are pins which are available with self-dipping drilling tip. And blunt tip, the tapered threads are usually a blunt tip. The thread length, ideally threaded part should not be outside the bone, and that's the way how you should choose how much is the thread length. And the thread type can be both cortical as well as cancellous. So here we have the full list. On the left-hand side, this is stainment pin, this shank screw. That is how the tips differ from each other. Just for the sake of completion, I have shown you a shank screw of this titanium also. These are self-drilling tips. People, I am not much in favor of it because I always drill separately and then put in the shank screw. But now the shank screws, there are available, which you can drill straight away, put the shank pin right on your drill and you can drill it right across. The self-tapping, I don't think you need any special kind of a self-tapping tip for shan screws, because even the trocar tip is self-tapping. You can have a Kansas threads also. I don't believe in they are much useful, because I believe the hold provided by the cancellous, by the Steinman pin and shan screws in an external fixator is not because of threads. It is because of the lever arm. So that's because of the point of fixation. But people say that the primary fixation and the hold stays longer for this. For that also, I think the number of threads is more important rather than the pitch of the thread, and the number of threads will be more with the cortical rather than the cancellous. This is the blunt tip taper thread. They are wider here, they are narrow there, and that is what is denim pin. The tip looks like a Steinman pin. You have threads right in the middle where it will be staying inside the bone. Now, shape zone is an important issue in any part of the bone, much so in the tibia as well. In the proximal part of the tibia, the anterior is not viable. You should have a 60 degree arc on both sides, leaving the anterior most 60 degree free of any pins. In the middle, you have only the middle and the interior part, because the rest of it is covered by the muscles and should not try to violate. That's how it's the medial. And the distal part, there are a lot of tendons. And there you see, these are the tendons. This is the middle part. There's a 90 degree arc of the middle part. This is the distal part. So there are lots of tendon. You should be careful. Here the arc available is just 60 degree. Often you have, for a tibial fixator, need to have a fixation in the foot. For the foot fixation, first and the fifth metatarsal are usually used. Length and material. Length according to the length of the bone, length of the rods. Now we are talking about the rods. Length of the rods, you have, in the rods, you have to consider two things: length and material. Length is according to the length of the bone. It is important for you to choose length in such a way so that it is never too long to protrude to the front of the joints, because that obstructs the movement of the joint. And material can be stainless steel, aluminum, and a carbon fiber. They differ in the weight and the X-ray assessment of the bone. That means the radio opacity. It's not moving. Okay, so now these are the tubular rods. On the right hand side, they are carbon fiber rod. On the left hand side, this one and this one are stainless steel. This one and this one are aluminum. There you have the tubular rods length. The basic principle is that there should be an ordinarily single rod for one bone. You should try to reduce the fracture and then put in one pin above, one pin below, hold it there with the second point of fixation like that. But it may not be sometime be possible, and then you can use two rods. That's the assembly then you are supposed to use. Use two pins on each of them, make a preliminary fixation, add another third rod, reduce, and then fix them this way. And then ordinarily two rods across a joint. If you have to cross a joint with an external fixator, you should have separate rod across the joint. That's the fixation for the knee joint. You have a separate rod for the femur and a separate rod for the tibia, and this is for the ulnar. So this is separate rod this is for the ankle. This is separate rod for across the foot, and these are two rods across the foot, and there is one rod in the tibia. So coming to the third component of external fixator, there are two types of clamp: pin to rod clamps and rod to rod clamps. There are different types. We'll be discussing each one by one. So this is the commonest kind of the clamp which is used, which is called adjustable single pin clamp. That's how it looks, shown in the blue. I have disassembled it. It is important for you to understand being able to disassemble and assemble it at will, because you must understand the mechanism of this also, because that's quite important. The versatility is increased by you just understanding this process. So that's the place where the rod goes. That's the place where the pin goes. This nut holds the pin. This nut and the clamp holds the rod. For this kind of universal clamp, you should always have a preoperative plan. You should plan preoperatively. What you should plan: the number of pins in each segment and the total number of pins over the tubular rod. Important is because you can slide these clamps on the rod. The conventional universal clamps on the rod from the side only. So once you mounted it, you will not be able to add another clamp. We will be discussing how you can do that, but then it is important for you to be always prepared for at least 2 clamps in each side. And if it is a bigger or a longer bone or more unstable, even 3 clamps. What you need to plan is that whether you will use single spanning rod also, or you will use multiple independent segment assemblies joined together by rod-to-rod clamps. If you are using rod-to-rod clamps, you need to add preoperatively that also, maybe in the middle, because you will not be able to add that later on. It has to be added in the middle to begin with, as is shown on the right side. So adjustable clamps, there's another kind of adjustable clamp. This is called a double pin clamp. Limitation is of this double pin clamps, both these pins very, very close. We already discussed that the distance between the 2 points of fixation is important. So I don't much use this clamp, but this is just for the sake of completion. There may be an application that when you are applying in a metaphyseal area, you might be using this clamp to have a 2 pins and a 1 pin above, but I'll show you a better clamp for metaphyseal fractures. Now, there is one indication for which the adjustable pin clamp does work, and that is this ankle arch. We discussed. I don't use this, but this is taken from a book, and you can use this adjustable double clamp, and they are quite useful when you are using these pins in the talus. So, say for example, your preoperative plan has gone wrong. You either forgot to add 3 clamps on the each side, or added only 2, or you wanted to add another pin. You wanted another clamp. So, if the preoperative plan needs to be modified, and you need to add another clamp on an assembled or a mounted frame, one thing is you can loosen all clamps, slide the rod, and add another clamp and slide the rod back. Caution is that you may have to redo reduction. To prevent loss of reduction, you can add another rod on the top while you are adding new clamp to the original rod. There is an elegant solution also, which is called rod over clamp. Some problem, I think. So, okay, now this is what is rod over clamp. Rod over clamps are also of 2 types. One thing which here we are showing is, which is called 90-90 rod over clamp. In this, there is only one nut which holds both the things. Here goes the rod and here goes the pin. And this is only the nut and the clamp which holds the both things together. The limitation is that there is adjustability is limited. You can have the rod and the pin at 90 degrees to each other. This is how it is assembled and disassembled. That's there on the rod. You can easily slide it from the side and then add. This is where it is shown. This is rod over clamp, which is called universal rod over clamp. It is fully adjustable. The difference from a conventional universal clamp is that the middle clamp which holds the rod is open from the side. So you can disassemble it, ride it over, and then reassemble it. And now you can add it in between. Now, that shows the difference between a adjustable rod over clamp and a 90-90 degree rod over clamp. This can be fixed only at this angle, whereas this can be rotated. I was talking about some important clamp for metaphyseal fracture, and I told you that the AOSF clamp, a tubular system, which we are describing, is actually a sectorial system. This is what a sectorial fixation with a tubular clamp. This clamp is called a trusses clamp. This is also a very interesting clamp. This is specifically indicated for metaphyseal or juxta-articular region. You can apply it transversely. The rod goes here, and the pins are the 2 pins can be attached on the same clamp. So you can have 2 pins, and they are quite distant, and they can be it is so designed that you can even escape the front 60 degrees range, so that you are in the safe zones only. So that's how it is done. This is the third clamp which is attached, which can be used for juxta-articular reason, but I would rather prefer it to be going here than there. So adjustable of pin to rod clamp. Now, pin, this is the system of AOSF tubular external fixator system is very versatile. The pin can rotate 360 degree on a fixed rod. The rod can rotate 360 degree on a fixed pin. The clamp can revolve around a fixed rod 360 degree, and the clamp can transmit along the length of the rod, and that is limited only by the adjacent to fixed clamp. That is by the point of fixation distance. So all these things allow you to do a preloading, a reduction, or a safe zone, a safe angle selection, and a point of fixation distance. Now, this is a small video, shows you how adjustable that is. So there you are. Once you have fixed the rod, you can rotate the pin. Okay, you can hold the pin stable. You can easily rotate the rod. Right? Then, if you loosen both of them, the pin nut is also loose and that is also loose. This is almost rotated up, down, round the rod also, up, down, front, back. It can be rotated in all directions. Now, adjustability of rod over clamp. Now, 1990 rod over clamp, I already told you that this clamp can only revolve around a fixed rod. It does not have the other adjustability. And a transverse clamp that can translate on a fixed rod in both mediolateral. The pins, I showed you the clamp has a slot. So the pins can translate on a fixed rod in both mediolateral and a longitudinal direction. Longitudinal direction is by the on the rod. The pin clamp can be turned up or down. You can make the direction of the pin going from the upper side of the clamp or from the downside of the clamp. And the clamp can also revolve around a fixed rod 360 degree. We'll be discussing all these things, how they are practically applicable in a case study we will be discussing later. Now the third kind, now we will coming to the clamps, which is called rod-to-rod clamps. So far we've been discussing the methods to fix the pins or the shank screws to the rods. Now these are the two clamps which are called the rod-to-rod clamps, left-hand side and right-hand side. We're discussing. Now, this is called universal rod-to-rod clamp. This is a limitation that in at least
2 more minutes, please, sir.
Okay. So these are the rod-to-rod clamp. Now we'll be coming to instruments. These are in triple trocar sleeve is a very important instrument because our innermost is for making the stabilization. The middle one is for drilling, and the innermost is for the insertion of the sand screw. This is triple sleeve is very important because you slide through the slot of the pin and you will have an appropriate direction. Long drill bit I talked is very important because if you have a short drill bit and you are using this triple sleeve, or even if you are not using a triple sleeve and you are going through the slot only, you will end up somewhere in between the bone and you will not be able to drill right across. These are the things which are used. Now, rod to rod coupled with pin to pin adjustability together permit a myriad frame assemblies, range limited only by your creative imagination. Here we are going a case study. This is a compound fracture of the distal tibia. That's the wound. The blue one are the universal clamps. They can be slided on the route from the side only. The universal rod clamp. The universal rod over clamp is this is the universal rod over. Universal rod over clamp is this one. And the 1990 rod over clamp is this one. The transverse clamp is this particular transverse. This one is transverse clamp. And then rod to rod clamp. This is one rod to rod clamp. And then rod to rod connection can also be done at a distance by something like this. You can add two clamps on the rod and then pass a pin between the pin slots and you can hold it like that also. This is another view. This is joining two rods at a distance with a pin passing through the slots and the universal clamp. There are two of them. Now, that's what is the transverse clamp looks like. This pin can translate right up to here. This pin can translate right up to here. Now, there are certain concepts in frame assemblies. They can be monolateral or bilateral, we talked about. They can be uniplanar or biplanar as well. This is monolateral, that's bilateral. The planes are something like this. So that's the monolateral frame. This is a bilateral frame. The frame is present on both sides of the bone. There's a monolateral biplanar. This is only one side of the bone, but there is one plane from above vertically and the one plane is horizontal. This is bilateral, but it's a uniplanar. The plane is the same. Now, this is bilateral and biplanar. This is present on both sides, as well as there is a 90 degree. This is called a triangular frame also. This is called bilateral biplanar. So I was talking a little bit of the preloading. So if you have a comminuted fracture, you are supposed to preload a little bit, bend these pins away from the fracture. And if you have transfer fracture, you can compress it. You can apply it in preloaded in the compression mode. So for preloading, there's a special clamp which is called Verbuke clamp. And there is one concept in that the oblique fractures are inappropriate for external fixation. For an oblique fracture, you can use a minimal internal fixation with external fixation, much like this. Motto of external fixator is primarily is first do no harm. That's the main point. So thank you very much.
Thank you, Dr. Malhotra. It was a wonderful talk, covered a lot of aspects of external fixator. We have some questions in the chat box. So there's one question. Dr. Wafai from Jammu and Kashmir, when choose nailing over external fixator in case of open tibial fractures?
I am supposed to take
Yeah,
this?
please.
Yeah, nailing can be done for an open tibial fracture. There have to be 2-3 things to be important. One is the patient presenting within 6 hours and the wound is safely not contaminated. Number 2, this can be only grade 1 gastruloma. It's a very much comminuted fracture with a lot of devitalized tissue. That's not an appropriate case of for a nailing, primarily nailing in a compound fracture. Third is that if you can debride and close it, that's the likely thing. So in all these cases, you can use and nailing also. The one thing which has been described in literature is that you should do an unreamed nailing in this situation. But I personally have done even a reamed nailing in such situation, and it doesn't much make difference.
Dr. Sumit, you want to add something to this? Unmute yourself.
I will be covering various aspects of this question in my talk.
Yeah. I think that will be better to. Any comment right now, Sumit?
I'm just. I will start my talk and during that talk will elaborate on this.
There's another question in the chat box. The query is when to apply a biplanar fixator and when to apply for uniplanar. How you decide in open fracture shaft tibia?
Yeah.
Considering that,
Yeah. The biplanar fixator, I'll describe them in the order of the stability. Uniplanar uniaxial is the most unstable. Biplanar biaxial is the most stable of them. Biplanar is to be preferred whenever it is possible, but biplanar means that you are going right across, and in that situation you have to keep the rod quite close to the bone, and you will not be able to take a good care of the wound. So in a case in which there is no inherent stability of the fracture, you would prefer a biplanar fixator. And when there is an inherent stability of the fracture, a uniplanar fixator would be good.
There was one more question: how to apply fixator for navicular bone or middle phalanx. I think this today's topic of discussion or seminar or CME is on external fixator linked to open fracture tibia or long bone per se. So we'll answer these questions in the next sessions of seminars will come in the advanced courses of external fixator. I think this message to Dr. Santosh Kabra from Madhya Pradesh. So now I will proceed to next. Any other questions on any other person? I think not. So far we're okay with this. So we'll proceed.
I would like to add something for the first question that has been put forward. When to choose nailing over external fixator? I think there is no absolute indication of choosing one over the other. It is more about the quality of debridement as well as the soft tissue contamination that determines when nailing has to be. One has to choose nailing over an external fixator. It is a more of a subjective decision than an objective decision, because if the quality of debridement is good and the patient has presented early and the contamination is less, so even in a grade 3A fracture, one can go for nailing. And but if either of the factors is against, then choosing an external fixator definitely is the right answer to begin with.
The second thing,
sorry, please.
Dr. Pradeep.
Yeah, please, sir.
In a compound fracture, we should pass on a take-home message that closure is not our attempt. In case there is devitalization, even if it is a grade 1 compound, debridement of wound is absolutely must. And there is no hesitation of leaving the wound open. As the things settle down, the wound also settles.
So the aim, I want to send the last message. The aim of this external fixator in open fracture is we don't want to land up the patient in infection, number one, and number two, compartment syndrome, right?
I have a comment. So the case study which I showed has actually a very small wound. You saw it. But if the soft tissue swelling is too much, you still would like to put in a fixator while you are taking care of the wound. It's not only about a wound care. The general soft tissue care is also better if you keep the fracture stabilized by an external fixator.
Correct.
Right. So the aim is to prevent the infection. Basically, we can delay for a few days also, but the discussion regarding nailing an external fixator, sometimes it's very subjective, sometimes it's very objective, and place to place and OT to OT. But after the second talk, we'll clear it out when we can plan for nailing and when we can plan safely for external fixator. Because at end of a day, even the fracture doesn't unite. We don't want to give the patient infection. That's very important. So we'll proceed to second talk, and the talk is on how to plan the open fracture management protocol. Management protocol by Dr. Sumit Arora. He's an associate professor in MAMC and very well experienced surgeon. Dr. Sumit, can you kindly share your screen, please?
Yeah, I am sharing my screen. I hope it is visible clearly.
Please go ahead.
Yeah. So to start my talk, first of all, it was a very enlightening talk by Dr. Manocha, where he described the external fixator nuances in great detail. And to start the principles of open management, the few introductory lines are: an open fracture is a soft tissue injury, which also involves the bone. So not only the bone, we should respect the soft tissue also. So it is primarily a soft tissue injury which differentiates it from the open injury and the closed injury. And one should not wait for the disaster to happen, as millions of the microorganisms are waiting there to fall in place. Thorough wound lavage may dislodge the microorganism, even the tough ones. And external fixation should strongly be considered under these circumstances. Unfortunately, the task of doing the external fixation is handed over to the junior most member of the team, which majority of the time is a orthopedic surgeon in making, that is a orthopedic trainee or who has just completed his basic training. And where the problem starts, because if one is not aware of all the nuances of and all the indications and the proper principles in hand, such type of trouble is likely to happen. And this may be the end result for the patient as well as for the surgeon. So with these introductory slides, I would like to highlight the basic principles of the open fracture. I'm Dr. Sumit Arora, faculty in MAMC and associated hospitals. So to start the talk, there are various classification systems that one must be aware of before embarking on the principles of the treatment. And there are various grading systems that focus primarily on the severity of the limb injury, which predominantly involves the Gastillo and Anderson classification system, and Cherney and the Gordsons. Similarly, there are scoring systems that focus on the patient status, especially in reference to the need for amputation or not, which clearly states in MES, mangled extremity severity scoring, and the NISA. So it is a nerve injury, ischemia, soft tissue injury, skeletal injury, shock, and the age of the patient. It is based on that. And there are few which are comprehensive systems that are based on the combination of these grading and scoring systems. And they are predominantly AO. Old one was the AO ASIF system, which was introduced in 1999. And later on, it was OTA classification system, which was introduced in 2018. And apart from that, Ganga Hospital score is also helpful under these circumstances. So to start, this is the modified Gastillo and Anderson classification system, which was modified in 1984. And despite its description for more than 30 years ago, it still holds its place, and it is one of the most commonly used classification system worldwide. So there are 3 types, and the third grade is further divided into 3 grades. So grade A, where the wound length is less than 1 centimeter with minimal or no contamination and with minimal or no soft tissue injury. And there is a bony injury which involves the simple fracture with or without minimal comminution. Similarly, in grade 2, it will be a more than 1 centimeter wound with moderate contamination, but without extensive soft tissue damage, skin flap, or the avulsions. And majority of the time, the bony injury is moderate comminuted. Similarly, in type 3, grade 3A, irrespective of the wound size, there is an extensive soft tissue laceration or the flap, but it maintains the adequate soft tissue coverage for the bone. And majority of the time, the bony injury is segmental or the severely comminuted. 3B is usually more than 10 centimeter long wound, and there is a high contamination following high energy trauma, and loss of soft tissue injury is severe enough to warrant any plastic or reconstructive procedure to cover the bone. And there is extensive periosteal stripping and the bony exposures. In type C, irrespective of the size of the wound, there is an arterial injury associated with the fracture that requires repair. So rationale of using this classification system, that it is a prognostic classification and it reflects the infection rate as well as the fracture healing time. In grade A, there is a minimal infection of 0 to 2%, whereas as the grades increases, it increases to up to 25 to 50% of the infection rate in grade 3C fractures. Whereas similarly, the reflection is seen on the fracture healing time as it increases, where the grades worsens, and up to 50% impuration rates may be seen in grades 3C fractures. This was predominantly described in fracture tibias, but it can be extrapolated to other bones as well, and it is most reliably done in operation theater after completion of the primary wound care, and it should not be done in emergency room setting. However, after its description, despite it remains the most commonly used classification system till now, there have been several reports that it poses poor inter-observer agreement as far as the classification of open fractures of the tibia are concerned. In this good study, the authors surveyed 245 orthopedic surgeons, and they concluded that it has moderate to poor inter-observer agreement as far as the open fractures of the tibia are concerned. So to close these gaps, various investigators have tried to make other classification systems to prognosticate the outcome. There was a good study that is based on the host classification system, was published in CORR, and it was described by Bowen and Widmeyer. And they combined the Gastillo-Anderson grades with the McPherson's staging. This is the same McPherson staging that we do for the possibility for judging the possibility of infection following revision arthroplasty. So they listed 14 host compromising factors and described the host grading into type A, grade A, B, and C. Grade A is uncompromised, that the host is having no compromising factors. Grade B is compromised, where they are having 1 to 2 compromising factors, and grade C is the 3 or more compromising factor is there. And the infection rate similarly varies between 4%, 15%, and the 30% across these grades. So they recommended that whenever someone is planning for operative stabilization of grade B and C, there is a marked risk of infection, and such type of patient should benefit from additional therapies in addition to the conventional ones. There was another classification system by Cherney and Gordzans. This is the classification system where they took into account of compartment syndrome for the first time, and they also took account into the subtotal and total amputations along with the open tibia fractures. However, this classification system is not commonly used in India, but it is very much in vogue in European countries. There is another good comprehensive classification system that is goes by the name of Ganga Hospital Open Injury Score. it pertains to limb salvage in grade 3B open leg fractures. They described the structures of leg into 3 units. First was the covering structures, other was the functional tissues, and other was the skeletal structures. And they gave 1 to 5 points each, and 7 comorbidities they listed, and they give 2 points to each. So the score of 14 or below was in favor of limb salvage, and 17 and above was in favor of limb amputation. Similarly, AO ASIF was the old classification system which was introduced in 1999, and they described open fracture as having 4 types, where the skin breakage was from inside out, less than 5 centimeter of skin breakage, more than 5 centimeter of skin breakage, and the full thickness contusion ablation, and the soft tissue defect is there. This is the newly described OTA classification system that was published in 2018, and they described it having the 5 parts and 3 points each, involving the skin, muscle, arterial injury, contamination, and the bone loss. So a cumulative OTA score of 10 or less was associated with a greater probability of successful limb salvage after the procedure. So having covered that, this diagnostic part of staging or grading systems, we will move on to the principles of the management of these open fractures. So the management should be done with the aim to convert the contaminated wound into the clean one, and then to convert the open fracture into the closed one, right? And there is another aim, that is to prevent the infection, both pyogenic as well as clostridial infections, and to achieve the bony union in sound position. So in an attempt to achieve these aims, the order of priority should remain as the patient's life should be kept as the first in priority, followed by patient's limb, and then priority come for the status of wound, and then the management of the fracture. So that percolates to the first is to preserve the life, then is to preserve the limb, and then is to preserve the function. So how to achieve these aims? There are various methods that have been described that can be covered under 4 heads: antibiotic prophylaxis, urgent debridement, fracture stabilization, and early wound cover. So these are the stages of open fracture care that have been described by AO manual in detail, which includes initial assessment, followed by primary and secondary operations, and followed by rehabilitation. So we will cover each in detail, including the surrounding controversy of each point, and what all are the current consensus that are being practiced nowadays. So initial assessment and management covers the advanced trauma life support protocol for injured patient, as everyone knows, and it also includes the distal neurovascular status of the limb where the open fracture has been there, because it is helpful in grading the fracture accordingly. Even with a closed fracture or a minimally open fracture, it can be a grade 3C. Right. So to start with the initial management, casualty room management involves the tetanus and the antibiotic prophylaxis and the various injections for the pain relief. Local irrigation is the must. Aseptic dressing followed by fracture realignment and the splintage. So when all these steps have been completed, one should always recheck for the distal neurovascular status before moving on to the next step. So this is a very pertinent, you can say, controversy or a topic of discussion in present day parlance, is the photographic documentation of the wounds. So this, all the hospitals should keep the option of such provision in their consent form under the umbrella consent for all the various aspects. And the photographic documentation is very important because it can be self-explanatory for various medical legal purposes. By taking the photographic documentation, it prevents various preventable re-examinations or the multiple re-examinations, and thereby decreases the possible contamination of the wound, because all the members of the team may not be of in unison with one particular modality of treatment. So they may like to see the wound at times separately. So if the photographic documentation is obtained, that may prevent such type of multiple examinations, and it is very helpful for the patient also. It has a great help in teaching learning activities of the unit, because there are various members of different level of maturity, and one can take help from the other's experience and grow further. Communication via digital photography is more useful than the verbal communication, because at times if a junior member is describing the wound conditions in detail over a telephone to a senior member, he may not be very comfortable listening to the immature description that is being given. At times a photograph may be self-explanatory under these circumstances, and it also makes the future retrospective analysis of the prospectively collected data very easy for the future publication purposes. So there are various recommendations for the management of open fractures. There were few questions that were being asked after the first talk, and I refrained from answering at that point in time because it was a lengthy talk in this aspect. So I thought of answering the question during the talk. So this was the very good critical analysis that was published in JBJS America, where they took various issues in hand for the management of open fracture and divided into A, B, C, and I. A, they termed it as the good evidence, which involved the level 1 studies with consistent findings, and B was the fair evidence, where the level 2 and level 3 studies were included. And in group C recommendation, grade C recommendation, it was a poor quality evidence because it was based on level 4 or 5 studies. And I was, there was insufficient or the conflicting evidence, not allowing a recommendation for or against its intervention, right? So to start with, whether we should use systemic antibiotics in open fracture. So the grade of recommendation is A. Definitely we should use. The antibiotics usage as a local therapy, the recommendation is not as good as that of a systemic antibiotic. Similarly, timing of operative debridement, there was some discussion going on after first talk. So the urgent, there are two types of operative debridements one can easily understand of. First is within 6 hours, that is also known as emergent debridement, and there is another that is done after 6 hours but within 24 hours, is known as urgent operative debridement. So there is though it is a conventional teaching that as early as possible is good for operative debridement, but there is a little consensus or recommendation in favor of doing the debridement within 6 hours. Rather, more consensus is there in favor of urgent, that is 6 to 24 hour debridement. I will follow further studies in this support later on my talk. Similarly, the high pressure pulsatile lavage and the usage of additives in the irrigation solution has got no recommendations. Similarly, femur interlocking nail following open fracture has got B. Under what circumstances I will describe. Likewise for the tibia as well. So I will coming on to these points one by one. To start with the antibiotics prophylaxis. So antibiotic prophylaxis should be given in open fracture. There is no doubt about it, and the grade of recommendation remains grade A. However, debate remains about the duration, mode of administration, and the type of antibiotics. So I have enlisted the current recommendations that are internationally accepted at the present parlance is that we should use for grade 1 and 2 open fracture is intravenous cefazolin 2 gram every 8 hours for 24 hours after the operative debridement. However, in those patients who are allergic to cephalosporins or the penicillins, one can use clindamycin 900 milligram every 8 hours for in place of cefazolin. Similarly, for grade 3 open fractures, intravenous piperacillin and tazobactam every 6 hours should be given for 24 hours after operative debridement. However, in patients allergic to it is intravenous clindamycin in collaboration with intravenous estrionorm should be substituted in these patients. The current recommendation is against using of fluoroquinolones in open fracture because there has been a debate of delayed bony union if the patient has received fluoroquinolone in any form. So these are the latest one that one should follow. Wound irrigation, the traditional teaching is copious normal saline irrigation should be done. And what is the copious for one particular injury is that the grade 1 open fracture, one should use a 3 liter normal saline. Similarly, 6 liter for grade 2, 9 liter for grade 3. If someone is having this sort of irrigation bags in their hospital, of 3 liters, and then it is highly recommended that we should use this rather than 500 ml, multiple bags of 500 ml, because opening the multiple bags multiple times may involve some sort of contamination there also. Method of irrigation, few initially propagated the pulsatile lavage system for the management of open fractures. But it was found that it was very effective in removing the particulate matter and the bacteria, but it is detrimental for the early bone healing, and it causes soft tissue destruction in already compromised soft tissue envelope. It is agreeable that it may dislodge the microorganism, but it can help them seed deeper also. So it was highlighted in a very good conducted trials as mentioned below. And the current recommendation is not in favor of using pulsatile lavage in the treatment of open fractures. Next controversy comes whether or when we should take wound cultures. So the appropriate timing to obtain these remains controversial. However, there is no role of taking cultures from the wound in emergency department. Bacterial cultures taken before or after debridement is also of no value. So the current recommendation is against that also. However, there is a recommendation to obtain the culture when obvious clinical findings of infection are present at the time of second debridement, and which is likely to help in antimicrobial therapy in these situations. So the timing of debridement was also being discussed shortly before. So one should debride urgently within 24 hours, not emergently, that is within 6 hours. It is based on the fact that debridement should be done because once the patient's medical condition has been stabilized, once life-threatening emergencies have been surgically or medically addressed, once appropriate surgical resources are available, including an inadequately trained and qualified operating room staff, appropriate assistance, and an adequately prepared surgeon. So this is a very wise statement, and the golden words are there. Neither emergent surgical intervention in the absence of physiological stabilization of the patient, nor prolonged elective delay is supported by the available literature or otherwise warranted in the management of open fracture. So if someone is able to arrange all these factors within 6 hours of treating the trauma, then one should not electively defer the debridement after 6 hours and within 24 hours. But it should positively be done within 24 hours, and other forms of treatment must have been started by then in the form of intravenous antibiotics and the irrigation. So it was a systematic review that was published in JBJS American volume that about the timing of operative debridement with respect to the infectious complications following that. So the data, they reported that the data did not indicate an association between delayed debridement and higher infection rates. And they suggested that the historical 6-hour rule has little support in the available literature. So within when all the factors are available and they are reasonably well controlled, then it must be done within 24 hours for sure. So this is now moving on to the next step of the primary surgery. And here the assessment of the wound and the limb is done. And the first step is the doing a trauma scrub. So this is the clinical photograph of the patient after trauma scrubbing. In trauma scrubbing, the soap and saline solution is used to remove the gross dirt. The wound are extended margins and resect the skin margins till the healthy skin margins are available, and resect the muscles till healthy contractile muscle tissue is available. It is very important to check the color, contractility, and the capacity to bleed to judge on the extent of resection of these tissues are required. The second step comes the re-scrub before we do the bony stabilization. So this is the clinical picture after the trauma scrub, and this is the clinical picture taken after the surgical preparation and draping following the re-scrub for the bony procedures. So next controversy comes to close or not to close the open wound. So the best available literature that suggested by D. Long et al. That they primarily closed 88% of their series and 86% of grade 2 and 75% of grade 3A wounds after optimum initial treatment. And they reported less morbidity, hospital stay, and the cost of treatment without any further increase in the wound infection. However, they suggested that there are few contraindications to primary closure of the wound, which involves the gross contamination and the inadequate debridement, form-related, firearm-related, and freshwater immersion injuries, delay in seeking medical attention beyond 12 hours, and compromised host or local tissue viability. They considered it against closing the wound primarily. And this was the concern for the grade A, grade B, grade 1, grade 2, and grade 3A open fractures. Now comes the concerns for the grade 3B open fractures. And the Godina principles of the flap coverage are worldwide known, that he suggested that flap should be done to cover the bone within 72 hours, and which was later on popularized by the concept of fix and flap concept for grade 3B as well as grade 3C open fractures of the tibia. And they suggested that flap coverage should be done early, if not urgent, but should be done within 72 hours, as the total failure rate of the flap was lesser in comparison to those which were done 72 hours. Partial flap failure rate was also less in this subgroup of patient, as well as the infection rate was also significantly less when the timing of flap coverage was within 72 hours of sustaining the trauma. So this is the reconstructive ladder for wound coverage. Majority of the grade 1 and 2, they are covered under primary closure and the second, or maybe the secondary intention wound healing. And majority of the 3A also comes under these headings, but in the further reconstructive ladder involving skin graft, local flap, regional flap, distant flap, free flap, or the tissue expanders, which may be used in this graded manner. So this is was the open fracture of the tibia, which was well reduced, and an external fixator with the carbon fiber rods were placed along with the placement of SSG. So despite the wound was crossing the midline, the result of SSG and the overall functional status of the limb as well as the fracture union went everything all well. However, there are dressing consideration that remains in selected group of patient where they fail to respond to other forms of treatment, conventional forms of treatment. Initial wet to later on dry aseptic dressings should be considered. Antibiotic impregnated paraffin gauze are very important. Semi-impermeable membranes, antibiotic bead pouches. These are the antibiotic bead pouches where the local delivery of the antibiotic is there beyond the minimum inhibitory concentration and leads to good control of infection and the exuberant granulation tissue formation. As similarly, the use of VAC is very gratifying in majority of the cases. Vacuum assisted closure I have seen in my practice, and I am quite satisfied with the results of the VAC, where the wound was deteriorating day by day. With the usage of this technology, it can do miracles at times. It is recommended for temporary management of the wound cover, and it removes fluids from the extravascular space, thereby promoting granulation tissue, reduces the edema of the soft tissues, thereby promotes healing, and improves the microcirculation. It also enhances the proliferation of granulation tissue, and this black portion is known as open cell polyurethane foam, which is attached with the tubing with the machine, which the machine involves the intermittent negative pressure, and this open cell polyurethane foam ensures the even distribution of the negative pressure across the wound and helps in healing. So now next and the last consideration comes regarding the fracture stabilization. Fracture fixation gives optimal.
Last 2-3 minutes, please. Huh?
Sir, last minute only.
Okay, thank you.
This is the last consideration. The fracture fixation gives optimal environment for soft tissue healing and reduces the chances of infection, because the repeated movement at the fracture site and thereby negative sucking effect on the bacteria inside the fracture site is reduced following fracture fixation. However, there are limited situations where we can do splintage only if the operative fixation was otherwise also not warranted or required. Internal fixation may be considered if the wound is clean and the coverage of the bone is readily available. External fixation should strongly be considered if the wound is dirty and extensive soft tissue injury is there. So these are the broad guidelines. However, grade 1 open fracture can be treated the same way as their close counterparts with similar results, as has been shown in multiple meta-analysis of the injury. Most cases of grade 2 and 3A can also be treated with internal fixation if other factors are optimally available and optimally controlled. As we all know that plating is generally recommended for majority of the cases of open fracture from grade 1 to 3A, fractures of the arm and the forearm, and the periarticular fractures. Intramedullary nailing is recommended for majority of the cases of open grade 1 to 3A diaphyseal fracture of the femur and tibia. However, controversy remains for reamed versus unreamed nailing for the open fractures of the lower extremity. Initially, around 10 to 20 years ago, it was being grossly and broadly propagated that one should not do reamed nailing in open fracture because it can suck the infection inside the medullary cavity and can increase the chances of infection. But however, as the time is going by, there is more and more consensus that is going more in favor of reamed nailing rather than going for unreamed nailing for open fractures, because by doing reaming, one can easily put a better sized implant inside, which promotes healing, and the stability of the fracture is also nicely provided. External fixation should strongly be considered for open grade 3 fractures where clinical milieu strongly suggests high probability of infection after internal fixation. So in this line, there is a scope of some sort of subjectivity, and it goes by the discretion of the treating orthopedic team, whether they should go for one modality or the another. So the external fixator is a device that is placed outside the skin and works on the relative stability and leads to healing with the callus formation. So its various advantages and the disadvantages and various nuances, how to apply and what all the precaution that one should be taken will be discussed in the next talk subsequently. And I will refrain from covering this talk here. So thank you. If I would like to take question here now, or I can take it later also.
Thank you so much, Sumit, for a very wonderful talk, extensive talk. You have covered all the points linked to open fracture as well as the basis of treatment of the open fractures. We'll take some questions right now. We have.
Yeah.
Any question from faculty itself?
Sorry, Sumit, you have already answered the question of the one of the members who had asked regarding nailing over external fixator.
Yeah.
I think with your extensive, very, very detailed, good talk, all those in between areas you have covered and you've cleared all misconception. Very good point regarding the urgent and the emergent debridement, as well as you have really put it beautifully. Very nice. One thing I just want to sort of ask, you gave a slide in which you showed flap and fix within less than 72 hours gives the best result. Even in the best of setups, sometimes doing a flap is very difficult within the 72 hours window. So if they are usually done a little later, according to your data, the failure rates increase manifold. So in your experience for grade 3, B and C, tibia fractures, open fractures, what is your usual protocols then?
It is agreeably, sir, it is very difficult to get the patient on table again within 72 hours for the definitive flap coverage. And majority of the current literature is in favor of doing it within 72 hours though. So there are few studies that have compared their flap coverage results that were done within 72 hours versus that were done at around 7 days, and that were done after 1 month.
Okay.
So they are also in favor that if not within 72 hours, one must focus on doing the flap coverage of the bone within 7 days positively.
Yeah, because getting the flap done is a multidisciplinary issue, and it involves a lot of efforts as well as cost. So you mentioned about the VAC usage. Lots of our delegates who are seeing this probably would be using it or have some experience. Can you give a little more detail on the VAC usage for their benefit?
So should I share my screen again?
I think we have time, Pradeep. Can we do that?
A few slides, 2 or 3 slides you can show.
Only one slide only.
Yeah, please.
Sure. So this is the usage of the VAC for those who have not been initiated into what all are the components and how it is used. So they must know that there are large black foam like structure that is inserted inside the wound, and they obliterate the dead space inside, as well as the small little cells within their shape helps in even distribution of the negative suction that is applied through them. So once the cavity is filled with this foam-like structure, there is a coverage option available in the form of the occlusive dressing, which has connected tubings with it, and that tubing is connected with this sort of machine where the intermittent settings are done, and that sort of dressing remains occlusive throughout the period when it is applied, and majority of the time it may be changed after every 3 to 4 days, or it may be removed when the collection of the exudates within the canister of the vac is very minimal, that is less than 50 ml in 3 days. So that is maybe the indication for its removal in the patients, and it promotes the granulation tissue formation very well, as well as it controls the infection like anything. So in my personal opinion, I am very satisfied with the use of the VAC in these patients.
Plus, it also reduces your requirement of antibiotics and stay in the hospital.
Yeah.
So repeated oozing, dressings reduce, so the overall cost actually comes down.
Patient can be discharged with this apparatus to home also, and he can come back and get the thing again done whenever.
Sumit, I want to ask one simple question, right? For compound fracture grade 2, right? You put some external fixator shaft tibia, right? Now, after 2 weeks or 10 days later, you want to plan for tibia nailing. It's a mid-shaft fracture, right? So you want to remove the fixator in the OT itself and do the nailing, or you take out the separate? How you plan?
So first of all, the index case, as you have described in question, was the grade 2. So if
wound is healed now.
If someone was able to do the good debridement and all other factors were reasonably controlled, then to start with, I would like to do intramedullary nailing on day 1.
No, plan. My question is, we have planned for fixator. We did the fixator. We are waiting for the wound to heal for another 10 days.
Okay.
Now we are planning for tibial nailing, right? After 10 days. My question is,
if the internal fixation has not been done on day 1 and the external fixator was chosen by the treating team on day 1, and if the wounds are healing well, then, and if we are able to remove the fixator within 10 to 14 days, so it is safe to do interlocking nail, and the fixator may be removed even in operation theater room setting itself if the pins are not infected. However, if for some reason the fixator has been there in place for more than 14 days, 10 to 14 days, then one must wait for the removal of the pins pre-operatively, and then clinical healing of the pin tracts, and then one should go for internal fixation in the form of the nailing. That will be the.
What is your take, Dr. Tandon? Because removal of external fixator for the patient also, it's a painful procedure, right? So taking to OT, again remove it, again taking back, again wait for 1 week. I'm just
No, Pradeep,
so
I
my
think
protocol is
standard protocol followed is what Dr. Sumit is saying. 14 days if the pins are there and the tracks are having no sort of necrosis or signs of infection, you can do it at one go. But if it is a little longer, then you have to remove it. Tibia is a very friendly bone. You can remove the external fixator without anesthesia, without OT. Like in my personal experience, I remove all external fixators in our minor OT without any anesthesia. The patient has to be fairly cooperative. And we apply a plaster, let the pin tracks heal, then we take him to the OT after a week or maybe 10 days. Because most of the times in those cases, you might need to also do a bone grafting procedure. So you will not exhaust all your means in one go.
Right. Thank you. Yeah. Sumit, you got two more questions from the chat box.
Yes,
the one question is from Dr. Maheshwar from Tamil Nadu.
Yeah.
Flap cover should be done within 72 hours. Is it confirmed or some delay can be done?
So the same question was, we have already discussed it with Dr. Tandon in detail.
Okay.
About the principles and
for the benefit of Dr. Mahesh, he might have joined late. Please repeat, Sumit.
Yeah. So I am coming to that slide.
You can be vocal, Sumit.
It was a conventional teaching was in favor of Godina's principle of flap coverage, where he advocated that it should be done within 72 hours, and it was publicized and was given the recommendation by various other studies also by the fix and flap concept, and within 72 hour and beyond 72 hour, they compared the failure rate of the flap as well as the infection rate, and both were in favor of less than 72 hours. However, in various institutions and as well as from the patient factors also, it may be very difficult for the patient, for the team to take him again to operating room within 72 hours of taking the of sustaining the trauma. So given the chance, there are other studies also which compare their result, that if the flap coverage is delayed by a week or so, or the flap coverage is delayed by a month or so. So after 3 to 4 weeks of delay, the infection rate and the flap failure rate rises steeply. So they suggested that if not 72 hours, then one must try to achieve that target maybe in 7 days time or so, because beyond that time, the vascularity of the bone, the viability of the bone ends that are exposed, they will start losing, and one will definitely land up in situation like non-union or something like that.
The last question is from again from Tamil Nadu, Dr. Sean Mugan. How long to give continue IV antibiotics and then oral antibiotics?
Yeah.
After this, we'll shift to the last
current
talk.
recommendation.
Yeah.
This is the current recommendation that this is the universally accepted classification system, and the same is being followed in majority of the setups, that in grade 1 and grade 2 open fracture after operative debridement, the prophylactic antibiotics have already been started before the procedure, and 24 hours after the operative debridement, these are the antibiotic, and this is the duration for which it is to be given. And this is for recommendation for the grade 3. However, there are few publications that are favoring more in favor of prolonging this antibiotic therapy for grade 3 open fractures beyond 24 hours to maybe 72 to 96 hours, but not beyond that.
Right. Thank you, Dr. Sumit.
Yes, sir.
So I hand over to Dr. Tandon now for the next talk, please.
Yeah. Thank you, Sumit. Thank you, Pradeep. And let me invite our last speaker, Dr. Ankit. Dr. Ankit is an undergraduate from Maulana Azad, and he did his post-graduation from PGI and SRship from AIMS. Now, Dr. Ankit is with the ESI institutions, as a faculty. Welcome, Dr. Ankit.
Thank you so much.
Share your screen.
Yeah. So I'm sharing my screen. I'm starting with my presentation, which is the topic for which is video demonstration of application of tibial external fixator. So I'll start with a short presentation and then I'll move on to the video part. So basically, the objective of my exercise is to understand the clinical indications of application of external fixator, a large external fixator in the tibia, to understand the choice of frame and the type of frame which has to be used for a tibia fracture, and to see and assess the positioning and insertion of the shank screw, and to find out how to apply a uniplanar as well as a rod-to-rod modular frame in an open tibia fracture. So my job has been made very easy by my previous speakers, Dr. Sumit Arora sir and Dr. Manocha sir, who have in broad detail discussed the indications as well as the nits and grits of application of external fixator, which I will be only revising when I discuss my video and show my video on application of external fixator in a sawbone model. So the clinical indications, as has been discussed previously, is severe soft tissue trauma either in an open or a closed fracture scenario, with damage control surgery being another indication, and in cases of acute and chronic infections of fractures as well as in non-union scenarios where external fixator can be applied. So the gross principle of fixator application is that two pins have to be placed in each of the two major fragments of the tibia, and which are connected by at least a single rod, and an additional rod may be added to increase stiffness of the frame. So this is the principle of application of a uniplanar external fixator for a tibia bone. The procedure is carried out in a supine position, and one has to understand the safe zones of pin application when one is putting the external fixator. The safe zone is a 60-degree angle formed medial to the tibial crests on the anteromedial surface of the tibia. So that forms the safe zone or the safe angle. And one has to avoid drilling on the tibial crest, because drilling on the tibial crest can lead to thermal necrosis. It can lead to ring sequestrum formation and can lead to pin loosening and pin tract infection as well. And similarly, once one is drilling on the tibial crest, one can slip on either side of the tibia to damage structures on the medial as well as the lateral aspect. One can damage the neurovascular as well as the tendons. So one has to avoid drilling on the tibial crest, and one has to follow the principle of drilling on the anteromedial surface, a 60-degree angle, which is the safe zone for application of shank screws on the tibia. So the first step is to obtain the reduction of the fracture when applying a uniplanar frame, and a pin is inserted in each of the major fragments to begin with, and the pins are connected by a single rod to which 4 clamps have been added. And at this point, one can, the reduction can be manipulated to some extent once this is being done, and this is the last step at which the reduction is modifiable or changeable. And once the reduction is stabilized, the clamps are tightened, and additional shank screws are placed on either side to stabilize the fracture. And once the pins have been placed, 2 pins on either side have been placed in a uniplanar fixator, reduction cannot be altered. So addition of another rod provides further stability to the fixation and to the construct. In severe soft tissue involvement, a pin may be added to one of the foot bones. A first or the fifth metatarsal bone is commonly chosen, and additionally, one can choose to put a pin in the navicular or the cuneiforms to get additional stability. One, and two, it can prevent equinus contracture at a later stage. So the common frames that are used for tibial external fixator is either a uniplanar frame or a modular frame. So this depends on whether the reduction is stable and is easily achievable or not. If the reduction is stable and easily achievable, one can put in a uniplanar frame. But if the reduction is difficult to achieve or it is rather unstable, a modular frame may be chosen where the fixator pins are put first and then a reduction is achieved, which is connected by tube-to-tube clamps. So this is the common instruments that are needed for application of tibial external fixator. So first is the a T handle with a Jacob's chuck, 11 number size spanner, a drill sleeve of 4 mm, and a 3.2 millimeter drill bit with an addition of a battery drill. And additionally, one would need the following implants. One would need 4 shank screws, 4 universal clamps, and 2 tubular rods. The tubular rods are standard AO type rods, which are of 11 millimeters. The shank screws that are used for large external fixators of large bones like tibia and femur is a 4.5 millimeter diameter shank screw, with a thread length of 40 millimeters. So again, as I've discussed previously, the safe zone is a 60-degree angle zone on the anteromedial surface of the tibia. And this is really important once one moves distally because of the neurovascular structures as well as the tendons, the extensor tendons and the tibialis anterior that is in close proximity to the site of pin insertion when one is putting a pin in the distal part of the tibia. So this is the shan screw, which is a 4.5 millimeter shan screw and with a 40 millimeter thread length and a 3.2 millimeter drill bit that is used to pre-drill the cortices when putting the external fixator. So since the core diameter of the shan screw is 3.2 millimeters, the drill bit is a 3.2 millimeter drill bit. And stability of a fixator can be further enhanced by the following means. In a uniplanar fixator, one can choose to put the pins closer to the fracture, which can increase the stability, which is depicted in this figure with the distance x. So once one moves closer to the fracture site, the stability increases. Simultaneously, one has to also take care not to put pins inside the fracture or close to the fracture hematoma. Similarly, in each fragment, if the span of the pins is further apart, that also adds to stability of the construct. And putting the tubular rod closer to the bone also enhances stability and increases the stiffness of the construct. Additionally, one can put a double tube fixator, which can where one can put two tubular rods on a uniplanar unilateral fixator that can enhance stability. In addition, one can use a biplanar frame or a delta frame where the pins are inserted at least a 60-degree angle, and this can also increase the stability of fixation. Similarly, one can use a transfixation pins, which was now seldom used, but it was a thing of the past that was commonly done to enhance stability, but this is avoided now to prevent injury to the neurovascular structures. In case of periarticular injuries, periarticular fractures, one can use a hybrid construct. A hybrid construct basically incorporates the concept of a tubular fixator as well as a ring fixator, where a combination of the two provides stability to a periarticular fracture. Additionally, one can use T-clamps or transverse clamps or universal multi-pin clamps to enhance stability in periarticular fractures where the amount of fragment or the amount of bone to put in the pins is rather small. So one can use these clamps to enhance stability. So I move to my, I will stop sharing my screen now, and then I will start sharing the screen with with the video. So I hope my video is visible.
Yeah, go ahead.
Okay. So this is the tibia bone with a stable fracture. The fracture is initially stabilized and reduced. The reduction is held with either K-wires or with a reduction clamp. And the reduction, once it's stabilized, the pins are then added. The first pin is placed in the most proximal part, about 2 finger breadths distal to the tibial tuberosity. Each fragment has at least 2 pins. After giving a stab incision of with an 11 number size blade, one introduces the drill sleeve, and after putting in the drill sleeve, a bicortical drilling is carried out on the anteromedial surface, middle to the tibial crest, with a 3.2 millimeter drill bit. After the cortices have been drilled, a 4.5 millimeter shan screw is inserted bicortically onto the tibia. And once the first cortex is gone, one always looks for the presence of the second cortex. And on reaching the second cortex, it is imperative to rotate the pin for 4 half turns till the time good engagement is achieved of the second or the far cortex. Similarly, after putting the first pin, the fracture reduction is again checked, and the distalmost pin is inserted, which is away from the metaphyseal part of the tibia as much as possible. And drilling is first carried out with a 3.2 millimeter drill bit, and the pin is shan screw is inserted in the distalmost part. Once the proximal and the distalmost shan screws have been inserted, a rod with 4 universal clamps is put onto the frame, and the rod is tightened. So this will be visible in the video in a short while. So once the 2 pins are placed, a rod is put onto the frame, onto the 2 pins with 4 universal clamps. The clamps are tightened, hand tightened first, and then the tightening is further done with the 11 number spanner. And all this at the same time, one has to ensure that the reduction is maintained and it is the fracture is provisionally reduced. Once the tightening is done, the reduction cannot be changed now. So after putting two initial pins, two additional pins are added close to the fracture. One has to ensure that the pins are as close to the fracture as possible, but one has to avoid entering the fracture hematoma or entering the fracture itself. The drilling and insertion of the closer pins is done through the universal clamps. So once all the pins are placed, the fixator construct is again tightened with a spanner of 11 number size, and one has to ensure that the skin, that the rod is sufficiently away from the skin, about 2 finger breadths on either side, to allow for soft tissue management at the same time. While tightening the clamps, one has to see that the counter force is given adequately. So after four shank screws have been fixed by the single rod, 4 additional universal clamps are placed to put an additional rod, and another tubular rod is railroaded through the 4 additional clamps that have been placed now. Addition of a rod enhances stability of the frame and gives stiffness to the construct, making it more stable. Again, while tightening, as I was saying, when tightening the pin side, one has to give counter force to the pin, and when tightening the rod side of the universal clamp, one has to give counter to the rod. So this prevents any change of the reduction or malreduction of the fracture when one is reducing the fracture and when one is putting the external fixator. After the rods have been tightened, if the fracture is a simple fracture, it can be compressed by slightly loosening the clamps and pulling the pins together. And if it is a comminuted fracture, one can do pre-tensioning by pulling apart the nearmost pins when loosening the clamps. So I think this is a very short demonstration of how to put a simple external fixator in the tibia. And once the fixator has been placed onto the tibia, this is how the pins are preloaded by pulling them apart. The pins have been pulled apart, and this allows for additional stability in cases of a comminuted fracture. So this is how preloading or pre-tensioning is done for the fixator. And additional dynamization can be carried out by allowing the patient to bear weight if the fracture fixation is stable. And bearing weight provides the best dynamization to a fixator construct. So that is it. Thank you.
So thank you, Ankit. Thank you for the slides and also a nice video. I think that's going to go helpful regarding the steps you carried out, especially for the second and the third pin placement and the use of the clamps, that you go through the clamps so that you are in line and then you are not struggling in passing the second rod. So that's good. So I have few questions which have already started for Ankit.
Yes,
Dr. Maheshwar from Tamil Nadu is asking, kindly explain regarding the delta frame in detail.
So a delta frame or a delta construct is done when one places additional pins using a T-clamp or a transverse clamp onto a fracture fragment. And then those pins are connected by tubular rods to the pins that are placed in the other fragment. So that is done commonly in fractures which are more close to the metaphysis, which are rather periarticular, where one uses a T-clamp or a transverse clamp to put in those pins. Additionally, a delta frame is done in a ankle spanning fixator where a Denham pin or a Stiemann pin is passed through the calcaneum, and universal clamps are placed on either side of the calcaneum on the Stiemann pin or the Denham pin that has been placed, which is further fixed to the main frame which is placed on the tibia. So that is what a delta frame is, and that is how a delta frame is placed.
So by actually extending the fixator assembly, you are taking additional anchorage with the foot, and you are making it biplanar.
In a way, yes, sir. It does become biplanar, and in addition, one can put pins onto the first metatarsal, or the second metatarsal, or the fifth metatarsal to enhance stability. So I think there was a previous question where one had asked about how to put pins in the navicular cuneiform. So I would just like to add, when one is enhancing the stability of the fixator construct, or one is planning to prevent inquinus contracture, one can put 2.5 or 3.5 millimeter pins in the metatarsals and the short bones of the foot. The tricky part is how to connect those to the large external fixator. So 3.5 millimeter pins can be easily connected to a 4.5 millimeter external fixator frame, because the upper diameter or the diameter that is connecting to the universal clamps, so that is same for a 3.5 millimeter and a 4.5 millimeter pin. The trouble comes when one is using a 2.5 millimeter pin for a smaller bone, say the second metatarsal or the tarsal bones. So when one is putting pins of a 2.5 millimeter diameter, one can use the distal radius distraction frames rods that are there, that they can easily be connected to the universal clamps, which can be further connected to the tubular external fixator, which is of 4.5 millimeter diameter.
So the construct that is necessary for especially the lower part tibia fractures, in case there is a compounding and you want to take the foot so that you avoid any equinus which will happen,
yes,
and also help get more stability. Plus, you like to weight bear these patients, right?
Yes, sir. To get them to dynamize, to get the fixator to dynamize, I would definitely like them to
So
weight bear as soon as possible.
do you dynamize your fixators as a routine?
Not necessary, sir. It is only when I'm planning a definitive external fixation, say for a transverse fracture of the tibia, which cannot be planned for a second surgery where a tibia nailing is carried out, one can definitely go for dynamization and then put the patient on a PTB after 6 weeks. So that is the only indication. That would be a rather rare indication in the current scenario, where I would like to take out my frame before 2 weeks and put and nail them.
But say you have to dynamize in the fixator with a double rod, can you explain to the delegates what will you do for each side to dynamize?
Sir, to dynamize, I would loosen the clamp which is on the tubular side and closer to the fracture. But it is only when I'm starting weight bearing, at least 2 weeks after putting in the frame, when I'm sufficiently sure that my fracture fixation is stable and the fracture configuration is stable. It is not oblique, it is not spiral, it is not comminuted. Only in those scenarios I would like to dynamize my frame by loosening the clamps which are closest to the fracture and then allowing partial weight bearing. So that even AO recommends that weight bearing is the only or the best way to dynamize a fixator.
So in a double rod, our teachers used to do this trick that you dynamize, you loosen the clamps of one rod distal to the fracture and the other rod proximal to the fracture. Yes. So you don't lose any sort of rotational or horizontal stability, and it just telescopes.
Right, sir. Exactly.
So I'll have to call in Sumit for a question which has been asked by Dr. Vijay from Tamil Nadu. What is the ideal pressure used in VAC? And will it differ from wound range? That means to say, any different categories of compounding, will you change the pressure?
The pressure remains the same. It predominantly based on the make of the company that is available to supply the thing.
What is the usual?
That are not there are no such fixed guidelines for that. That is available anywhere.
Sir, I would like to add a bit. Sorry, sir. Sir, I would like to add the common pressure that is commonly described for large wound is 100 to 120 millimeters of mercury, which is best given intermittently rather than giving a continuous pressure. But then this pressure varies from the design as well as the make of the VAC machine.
Yeah.
One more question, Ankit, is again from Dr. Maheshwar from Tamil Nadu. Should mirroring of rods done on same side, or the rod can be on opposite side of the first rod? Does this make any difference in stability?
So I think based on what he's saying, he's talking about a frame where the pins have been transfixed across the tibia onto the other side. So this was a concept of the past, but right now, since the safe zone is described to be only 60 degrees on one side of the tibia, I would rather advise my junior colleagues to avoid putting frames which have pins that are driven right through the tibia from one side to the other, rather than, if one needs to add stability to the fixator, one can put in a delta frame or a biplanar fixator where pins can be put in at a 60-degree angle which can give enough stability for any sort of fixation rather than putting transfixation or mirroring rods. Can be placing mirroring rods on either side of the bone.
And the construct can be made like a pyramid, and you can gain a lot of stability and rotational stability also.
Especially when one is planning for a definitive external fixation for managing a fracture.
Right. So, any other question, Dr. Pradeep?
I don't think so. Any other questions there? Any question from faculty itself? Or Sumit, you want to ask anything? Or Shobit, any question on chat box from your side? Anywhere else?
No, doctor.
Yeah.
So, I think this was an extremely well discussed topic, very, very important. And like one of the faculties said, most of the times it is given to the junior most trainee of the team. And if they are not well versed with these concepts, a beautiful device which can give fabulous results is having a lot of complications. So I hope this masterclass of today has helped everybody clear their doubts and also introduce them to the latest and the best concept, best practices. So I'll hand over to Dr. Pradeep.
Yeah. Thank you, Dr. Anand. Can you stop sharing, Dr. Ankit, your screen, please?
Yes, sir. Sure. Right.
So now we have finished all the 3 talks and we are open for discussion. If any other questions is there, Dr. Ashok Shami is there from Pune. Dr. Sumit, you want to add some few more points?
Things has gone okay, I think. All the points were discussed.
Sir, I would like to ask something from Sumit Oda, sir. Sir, what is the current protocol in MAMC for IV antibiotics usage in open fractures? As you said that the duration is rather very short as in the literature. And what is the current protocol that you are following in your institute, sir?
You are asking specifically for the open fractures, right?
Yes, sir, for open fracture. Yes.
I would rather stop all the antibiotics within 7 days of sustaining the trauma, especially if I am dealing with a grade 3 open fracture. Grade 1, they may be treated as the same thing as that was a closed one.
Okay, sir. And no oral antibiotics after the 7 days are over?
This is including oral and injectable. Okay. There are few patients that where I can shift to oral a bit early also, or I can continue whole 7 days for injectable only.
So, Ankit, I think we all are having a tendency to definitely overuse antibiotics.
Exactly.
And compared to whatever data and studies, especially what Sumit showed, I think our antibiotic use, we tend to overuse.
Yes, sir. That is
personally, and I think we all would be sharing that it is IV antibiotics in compound fractures for 3 to 5 days at least, followed by oral antibiotics till the wounds are dry.
Exactly.
Yeah. I want to add one point, Sumit. I think in your one slide you said never send culture from the ED, right?
Yeah.
But I feel we can always send one culture from ED and one culture, one speed, one of first debridement, right? So this is my protocol. And
so there has been rationale behind that concept, because it has been observed that up to 18% of the patients whose culture was sent in emergency room, and ultimately the organism was somewhere else, or they did not get infected at all. And there were few good subset of patient, up to 22% of the patient, where the culture was reported as negative, yet they developed the infection. So sending the culture in emergency room or in operation room before debridement or in operation room after debridement is not recommended.
So Sumit,
your suggestion is when we can send the right culture, second after first debridement or after second debridement, when you want to send it?
Whenever there are signs and symptoms of clinical infection, and at the time of second debridement, it is recommended to send the culture only then the appropriate antimicrobial therapy may be directed. Otherwise, all those reports will be confusing for the treatment protocol, and they are not of use as far as literature goes. And that is what I am following here.
So have you ever asked for serum procal once you admit those patients, like polytrauma patient at the time of admission?
It is not available in my institute at the night hours.
Right. Just for theoretical purpose, do you really feel serum procal has really any value for making the sepsis notification today or maybe after 5 days?
I need to see for its use in open fracture. I am not sure.
But Tandon, you were asking some question.
Yeah, sometimes the patients are not reaching your institution immediately. So they might have already crossed the 1 or 2 days somewhere. Sometimes you would have also seen sutures have been put on a grade 3 and a plaster or some support has been done. Will you take a culture in these patients? Will you also consider them to be already contaminated, infected?
Now, those patients have already crossed all those recommendations that were laid, that were expected to be checked before they were there at the treating hospital. So, at that point in time, where there is a overt evidence of infection already present in those patients, we would like to, and we should send cultures then and there.
So the take-home message with Sumit you are trying to say is, if it is a direct reach to you, contaminated but relatively fresh, you will not do the immediate culture or base your treatment on the culture.
Yeah.
You will do your debridement, do your fixator or whatever plan. Second debridement, if you see signs of infection setting in, then you will take the culture.
Yeah.
If there is a patient who's referred out and there is a time lag which looks to be contaminated going to infection, you will treat it with the culture and then proceed.
So that patient will be akin to the second debridement only.
Second debridement. Yeah. Right.
I want to add one point here. We all are orthopedic surgeons, right? And we involve our physicians guy once things start complicating. So in my practice and what I do always in polytrauma or maybe single fracture bone, wherever there's a compound fracture, I always involve one of my physicians with me, because sometimes we are so much focused on the fracture, then the systemic kidney problem starts coming up. AK happened because we are not sure how much fluid and potassium treatments and what else for sodium, whatever, but sometimes bicarbonate they give. They are very well trained into prevention of therapy for kidney. So always take one consultation with a physician to avoid nephrotoxicity, which happens due because of injury, or maybe once we are reviving the patient also, it happens sometime. So this is very important. Myoglobins comes up, AK happened post-op. I've seen a lot of time because we are very focused on our fracture, fixator, flap, and everything else. So that management miss out sometime when you're a single surgeon somewhere. So have a physician with you. Maybe patient is no comorbid, nothing. Patient's fit, 25. Still add on one consultation because he covers a lot of other factors which we missed as a surgeon, as orthopedic surgeons. What is your take on Dr. Tandon? What you do? I think so.
No, as my hospital protocol, every patient needs a physician clearance when we take them to the OT, and the immediate polytrauma patients especially, we have to have a physician in our team. So all those other factors are already covered. And I think being on the private sector, we are more exposed to litigation.
Yeah.
I think it is a correct advice that those all concepts are covered. That was a very nice thing Dr. Sumit showed, that use of photographs is for learning as well as for documentation and protection of the doctors and the team, that how did the patient arrive. Especially for the grade 3Cs, we've seen that they usually come that the circulation was there, the limb was warm, you did something wrong, and now the leg is being cut. So for all those reasons, I think documentation, having more members in the team is ideal, necessary. And Ankit would be seeing more of these industrial accidents also coming to you
That is very
at
true.
your centers.
Definitely. A lot of labor injuries that come to my.
Like sometimes there are machine injuries with a lot of grease. So what do you do for such sort of cases in a compound fracture with grease?
So grease is something that is very tough to get off again, one. And labor injuries are fairly common where I work because they have a lot of industrial, there is a huge industrial area that my hospital caters to, and a large number of patients that come to us have open fractures, especially crush injuries of the hand and upper limb are fairly common with the patients that I face right now. And it is again tough debridement, especially in the first stage when a patient is taken to the OR and a simple wash is very difficult to. It is very difficult to get off all the grease and other contamination by a simple wash. It is we fairly use scrub and soap water to get off all the grease and associated contamination that is there in the wound. And even after thorough debridement, one has to. We tend to leave the wound open for either a vac application or thorough lavages that are done in the ward till the time the wound is healthy for a subsequent skin cover or a flap cover. And that is how things are managed at my place, especially with the large amount of industrial trauma coming in.
One more thing comes to my mind regarding the culture. If there is a road traffic or a farm injury patient with an open fracture coming right away, your culture, Sumit, I'll want your opinion. Will it be helpful to rule out Clostridia contamination for future?
Only if the microbiologists are sensitized that you want to get the Clostridial in culture also done. Because majority of the cases in the middle of the night, they would only screen for gram positive and negative cocci and not the detailed Clostridial and anaerobic organisms.
So a sample sent cannot be put to a liquid culture which can be subcultured later on in the day?
Majority of the time, it is not feasible.
It's difficult. Yes, Ankit, you want to add?
Sir, I would like to add to what Dr. Sumit sir is saying, that Clostridium culture is rather tough. It is difficult. It requires special anaerobic media to transport as well as do those cultures because with the availability of the Robertson cooked meat media and other media that are there for anaerobic culture transport as well as to do those cultures, and the microbiologist again has to be sensitized, one. And two, it is with a large amount of contamination, it is very difficult to isolate a single organism from the microbiological milieu that is there in an open fracture with a lot of contamination. It is only possible only when the first debridement has been done and subsequently washouts have been done that an infection starts to set in, when the surgeon feels that there is a Clostridial infection or the patient is going into some sort of a gas gangrene-like scenario where one can go for these cultures. It is practically very difficult to suspect and do that in every patient, where only a very small minuscule number of patients would have such an infection.
So it's not cost effective, right?
It is definitely not cost effective.
Yeah.
Apart from being cost effectiveness, it is not very feasible also at times, because majority of the time the decision has to be taken on the table. We cannot wait till the Clostridial culture report is there whether to close the wound or not. So at times the surgeon would have to use its discretion or by subjective means or the experience whether to close this sort of wound or not. So whenever in doubt, one should go in favor of leaving the things open.
Right. So for open fractures with suspected gas, I think your heavy masks definitely are impediment, and probably the smell of this wound is also of help, besides the color and the consistency of the muscle.
Exactly.
Right. I think we've covered good amount of topics and issues related to open fractures, especially to the tibia and other areas. Anything else? Last closing remarks?
I think nothing on the chat.
Yeah, Dr. Maheshwar from Tamil Nadu is again asking, in biplanar external fixator, apart from placing anteromedial shank spin in direct placement, on pins on medial aspect in another plane is advised. So I think, Ankit, you've already answered him this.
Yes, sir. Because anteromedial pins are safer, and putting the pins on anterolateral side will impale the tendons on the anterolateral side, the tibialis anterior and the extensor tendons, so it is rather avoided. And biplanar frame can be put with a good 60-degree range of safe zone that is there. Right. Another thing that has been asked is, can a locking plate be used as an external fixator? There have been some reports or somewhere commonly that we see on WhatsApp groups that there is a tibial plate that lies right outside the bone and right outside the skin, which has been where locking screws have been placed as an external fixator. I really don't have any personal experience with that. I think other faculty can guide me more on this. I have seen it. It looks technically sound, but then personally, I have no experience with putting locking plates as external fixator.
We are discussing here only external fixator and open fractures, so we'll stick to that only.
Yes, sir.
Right. So there's a last question. Dr. Ashish Singh from Delhi is asking, any literature regarding single, double, or triple IV antibiotic use? Dr. Sumit, can you answer, please?
As I have already discussed regarding the current recommendations of the antibiotic therapy that are in vogue in present day and time, for grade 1 and 2, the antibiotic of choice is intravenous cefazolin. And in those patients who are sensitive to it, it may be replaced with a clindamycin. And in those patients who are open grade 3C, the antibiotic of choice is piperacillin and tazobactam.
So in Tamil Nadu, apparently cefazolin is not available as reported by the delegate. So can you give an alternative to the same?
So if the patient, the recommendation in literature is regarding the patient allergic to cefazolin or the penicillins. So if the antibiotic is not available in some particular area that I am not aware of, someone is saying, then there must have been some issue. So for grade 1 and grade 2 open fractures, the recommendation is in favor of IV clindamycin. And in those patients of grade 3 open fractures, the recommendation is in favor of clindamycin plus aztreonam.
But cephaloxolin would be any other cephalosporin you would like to recommend besides cefazolin?
The recommendation is in favor of first generation cephalosporin, and most commonly used one is the cefazolin only.
Yeah.
Alternatively, commonly used that we use Supacef or the Monocef, that is also very commonly used, ceftriaxone and all. So if those things are not available, then they may be substituted with this also.
You won't mind going to a higher generation of cephalosporins?
Majority of the time, we stick to cefazolin only.
Okay. I think, Dr. Pradeep, we have been before schedule for the first time. And
we are right on schedule.
We are right on schedule, and we should congratulate all the three speakers
they well covered everything.
Fabulous talk.
Yeah.
And answered all the questions.
So much, sir. Thank you so much. I thank DOA for this opportunity. Thank you, everyone.
If there's no more questions, so can we close this after discussing with Shobit?
Yes, doctor.
Do you have any questions pending with you? If you see some.
No, doctor. No.
No, I think we can close it, Dr. Pradeep.
Yeah, so I'll just give a closing remark.
Please.
Yeah. So thank you, Dr. Manocha, Dr. Sumit Arora, and Dr. Ankit Khurana for wonderful covering all the three topics. And I appreciate your inputs on Sunday evening. And it will be great help to all the practicing surgeons, young or maybe seniors, wherever they're practicing. And cutting remarks from Dr. Tandon. Thank you so much, Dr. Tandon, for the same, for contributing to this seminar. And because it's very basic talks and very important talks, aim is, and Dr. Sumit's slides are very good. Life is more important than fracture, healing, and all that. So we have to look after, we should avoid infection, because fracture can be taken care later on, but infection once happen to bone, it's very difficult to take care. So aim of this seminar is to avoid infection at any cost. We can delay, we can have more opinions, refer to higher centers, and how to give a good external fixator to avoid vascular injury sometime or giving nerve injuries also sometime. And I've seen putting fixator even stimulant pain causing LPN palsy. So at this, I thanks also the omniquarist Mr. Shobet for giving us this platform to present our knowledge and sharing our knowledge and discussing new points for present scenario. And Dr. Sumit has covered recent literature also, what's going on world over. Thank you, everyone. And with this, I close this session for today and have a great evening.
We have missed Dr. Lalit and Dr. Hitesh Lal. And
yes.
Thanks to Lalit and Hitesh and DOA.
Yeah, please.
Have a lovely evening. Good night.
Yeah. Thank you so much. Thank you so much, Sumit, once again.
Thank you, sir, for giving the opportunity. Pleasure, sir.